cardiovascular disease continues to kill more women than men annually in the U.S., and while CVD rates have declined in older women, rates have actually increased in younger women. So we are here to talk about this topic, sex differences in cardiac risk factors, perceived risk, and healthcare provider discussion of risk and risk modification among young patients with acute myocardial infarction. This is the VIRGO study. And I am with Dr. John Spertus, who is an MD, MPH, Director of the Health Outcomes Research at St. Luke's Mid-America Heart Institute, and a professor at the University of Missouri, Kansas City. Now, most of our viewers are likely well aware of the WISE study. Maybe not so much with the variation in recovery role of gender on outcomes of young acute myocardial infarction patients. That's VIRGO. Tell us about VIRGO.
So VIRGO is a remarkable study. It emanated from early work that Harlan Krumholtz and Viola Vaccarino did that was published in the New England Journal of Medicine that showed a remarkable increased risk of mortality in young women presenting with a heart attack, those below 55. And it is true that women are much less likely to have a heart attack than men in this younger age group because of the protective aura of estrogen or whatever it is, we don't fully understand, that protects women for a decade longer than men. But once they have a heart attack, especially these younger women, they have a much higher mortality rate. Nobody really understood at the time that funding for VIRGO was obtained whether or not this would extend to their symptoms, function, and quality of life. So there's a very strong desire to understand health status outcomes beyond survival. And similarly, there was not a very deep understanding of why younger women would have such adverse risks compared to men. And so they took a very broad view of trying to understand psychosocial risk factors, baseline health status risk factors, socioeconomic risk factors, gender and role responsibility risk factors, patients' perception and understanding of their disease before they had a heart attack, and how they had been counseled or educated by their doctors about their cardiovascular risk factors. And this initial study is one of the early and important foundational papers to really try and understand, do women view themselves as being more or less at risk than men? Do they get less education and less counseling and less aggressive risk factor modification than men? And do they have more or fewer risk factors than men when amongst a young group of men and women presenting with a heart attack? This concept is actually extended there are a couple of Canadian studies that are also looking at this population, but VIRGO is, I believe, the largest, and we're going to start seeing a lot of data and novel insights into some of the different characteristics of women and men, particularly the younger women and men, what their outcomes are, and a real aggressive effort to try and understand some of the mediating factors of these potentially worse outcomes so we can improve care and outcomes for this vulnerable population.
Now, this paper that we're talking about is being published in the November 3rd issue of JACC. What did you find?
So this was a very interesting study in that it looked at the distribution of risk factors for men and women, which is not perhaps the most novel thing. That's been looked at before. But what they found was that women tend to have more risk factors than men. They were more likely to have diabetes and obesity. They had similar rates of hypertension and less dyslipidemia than men did. But it really went a step beyond to try and understand from women's perspectives, did they perceive themselves to be at risk for heart disease? I mean, a lot of these women, they're caring for toddlers or they're caring for, teenagers. They're running around. The last thing they think about is that I could be at risk for a heart attack. They could smoke. They could, have diabetes. They could do this. But the idea that they actually are at risk for a heart attack and that there's something to do to prevent that heart attack, or when they feel the sudden onset of chest pain or symptoms, to realize this could be a big deal. I need to call 911 and not take some Maalox and lie down for a couple hours. I mean, these are important issues, and we have to try and get a deeper understanding of why, how do women view themselves and their cardiovascular risk if we want to create creative, proactive strategies to help these high-risk individuals understand their risk and to seek the care that could benefit them. And we frankly also found that providers educated the women of their cardiovascular risk less than they educated the male counterparts of a similar age. And I think the aura of protection for younger women permeates not only patients but providers. And we all need to realize that, these weren't, this is enriched for a group with a lot of risk factors, but they had a lot of risk factors, and less than half had ever been told they were at risk for cardiovascular disease. And that's something that I take to my clinic that I need to think more about when I see people.
But that also means if you have a lack of risk assessment, you probably have a lack of preventive therapy.
Correct. A lot of these were assessed and treated, but you're right. I mean, if you don't even look, you can't ever find and you can't treat. So that's right. We do need to be aggressive in thinking about that.
I mean, there was an accompanying editorial comment by Noel Berrymers and colleagues, Gender, Cardiovascular Disease, and the Sexism of Obesity. And they write of the cultural gender bias and objectification of women in this country, and healthcare providers maybe too, that is assessing CVD risk in women according to objectified appearance and body weight rather than validated risk factors, which I thought was an interesting take on this. Do you agree with that?
Well, first, I think that's a provocative statement. And, we clearly want to engage patients in understanding their cardiovascular risk from objective factors. I mean, I actually think I'm a huge fan and admirer of the work of Noel Berrymers, and I think she's very passionate about this issue, and I think she may have overstepped a little bit what at least I would have done, how I would have interpreted the data. We do want people to routinely and systematically get their risk assessed. And a lot of our current insurance programs are actually forcing health risk assessments and periodic assessment of risk factors to get lower co-insurance rates. Now, this doesn't help the completely uninsured, and some of the Medicaid programs are moving in this direction. And as we shift our focus to population health, we need to stratify the population into high and low risk individuals, irrespective of gender. And I believe that we're starting to see more and more movement in that direction, and we'll continue to see that. And then we need to distill these risk factors into a more objective risk. And you're seeing some of that with the updated guidelines on when to initiate statin therapy based on cardiovascular risk. We need to do that. And we need to create and think creatively about how we can activate patients to be more deterministic in the care that they want to receive. I mean, if patients are advocates for themselves and are educated, and the American Heart Association has done a lot to try and support this, are educated about their risk, and the Go Red campaign for women is one important step in creating a foundation, but we need to go further for people to really understand what their personal risks are, how they can modify those risks, and why they should modify those risks. And it's an important message. Angelina Jolie did an amazing job about increasing women's concern and recognition of breast cancer. We need to see that kind of public upswelling of interest in trying to understand cardiovascular risk factors and to have the passion and commitment to address them.
Well, one of the ways is simply to look at your paper, because you really do have some ideas in there how to close gender gaps within the guidelines. And like you said, there are some various things you can do.
Yes.
And so we should be optimistic.
I am optimistic, and I also would just highlight that we didn't do such a great job for men either, right? I mean, we weren't perfect for either. And so, while I would like to see a narrowing of the gender gap, I would like to see both sexes benefit from greater cardiovascular risk appraisals, recognition, and proactive treatment to minimize heart attacks and death.
Please check out the paper that we're talking about. It is in the November 3rd issue of JACC. For Cardiol Source World News, I'm Executive Editor Rick McGuire.